Good evening. Welcome. My name is Louis Weiner. I'm with the Marin Healthcare District. Thanks for coming to this important event. This is the seventh in our series over the past 2.5 years that we've presented on important health issues of our time and our place. First of all, I want to thank our district board members. A few of them are here. Could you please stand up and let us know? Yes, these are the ones that make this all possible. Thank you. In this health seminar series, we've had several different subjects. We opened with we have social isolation, which we had recently, an important issue for the elderly. Suicide, men's health, vaccines and immunizations, opioid epidemic, and the End of Life Options Act. The next one coming up in June is on dementia. So this is an important one on women's health, particularly women in cardiometabolic health. And we're great and happy to have Dr. Linda Gaudiani and Dr. Szady here presenting. They'll each give about half-hour presentation with Dr. Szady beginning, and then afterwards there'll be a Q&A session. So welcome.
So to start off, I have no disclosures. All right. Our objectives for the next 30 minutes or so are to define what is heart disease. All right. We're going to discuss the epidemiology of heart disease in women. We're going to discuss risk factors for developing heart disease. And we're also going to discuss methods for preventing heart disease. So what is heart disease? When I say that, what do I mean? Okay. It means heart attack. It means stroke. It means coronary artery disease, or buildup of plaque or cholesterol plaque in the heart arteries themselves. It means peripheral artery disease, which is buildup of that same plaque, but in different blood vessels in the body. And it means aortic aneurysm. Okay, so heart disease is a blanket term encasing all of these. So let's look at some of the facts. Okay, heart disease remains the overall leading cause of death in women in the United States. Okay, in ages 85 and over, it is the #1 cause of death. For ages 45 to 84, it is the #2 cause of death, with cancer being the #1 cause. And that is only a recent development. And so we are making headway when it comes to heart disease in women, but it is still highly prevalent. Okay. In 2017, I'm using epidemiologic data from the CDC and the National Vital Statistics. So all of our epidemiologic data lags a couple of years. Takes a while to gather and process. So this is the latest data we have is 2017. Okay. Heart disease accounted for 21.8% of deaths in women in the United States, and cancer accounted for 20.8%. So they're very close together. Okay. Heart disease killed almost 300,000 women in the United States in 2017. Okay, that is not an insignificant number, 300,000. Okay, that means it kills every 1 in 5 women. Okay, it used to be 1 in every 3 women. Okay, but 1 in every 5 is still too high. There are common misconceptions we have about heart disease, especially women. Myth number 1: heart disease is for men. Cancer is the real threat for women. Okay, well, let's go over some of the data. Okay, fact: heart disease accounted for 24.2% of deaths in U.S. men. In 2017, it was about 350,000. In the same year, it accounted for 21.8% of the deaths in U.S. women, and it was about 300,000. So only 50,000 difference. Not that much. Okay, 2019. There are about 270,000 women in the United States diagnosed with breast cancer. Okay? Unfortunately, only about 42,000 women died of breast cancer. All right? So you are 7 times more likely to die of heart disease than you are of breast cancer. Okay? And I'm not going to say it's not important to get your cancer screenings. We all should do it. And we all hear it all the time, but we don't hear about the issues with heart disease. Okay? So I'm here tonight to tell you that it is a problem. It's a big problem, and it's a problem for all of us. Another myth: heart disease is for older people. Okay? Among females aged 20 and older, between the years 2013 and 16, 44.7%, about 45% had some form of cardiovascular disease. Right? 45% starting at the age of 20 and on. Okay? So just because we're younger doesn't mean we're not at risk. It doesn't mean you don't already have it, okay? Another fact that we don't hear about enough is for younger women, the combination of birth control pills, oral contraceptives, and smoking boosts the risk of heart disease by 20%, okay? So that's huge, all right? And I don't know how many women are told that, okay? Another misconception is I don't have any symptoms, therefore I am not having a heart attack, okay? Wrong, okay? 64% of women who die suddenly of coronary heart disease or a heart attack had no previous symptoms, right? 64%. Symptoms vary greatly between men and women. So if there is 2 things you take away from this talk tonight, 1, heart disease happens in women a lot more than we think or know, and 2, symptoms vary between men and women greatly, okay? So we're all taught, you know, elephant sitting, on your chest, pain in the middle of your chest, you can't breathe, crushing chest pain. That is a telltale sign of a heart attack, but usually in a man, okay? For women are more likely to experience shortness of breath, some nausea or vomiting, some jaw pain, some pain in between the shoulder blades, even flu-like symptoms. I've seen many women presenting with an acute heart attack saying, I thought I had the flu, okay? So just because you're not having that elephant sit on your chest doesn't mean you're not having a heart attack, okay? Other symptoms are dizziness, lightheadedness, fainting, or kind of upper abdominal pain, okay? Another issue is women often seek medical treatment later than men, okay? On average, when women present for a heart attack into the emergency room, they present 4 hours later than men. Okay, so this is a little clip I have from the American Heart Association. It's a little spoof that really kind of hits home here. Excuse me.
It started out like a totally normal day.
Mom!
Okay, move objection deadline to the 3rd line after survey. Oh, honey, for when you write, always use the verb start. What are you doing down there? Did you finish your breakfast?
Ow.
Don't hit your brother. Honey, you have to eat something. Here. Okay, 5 minutes to carpool. Where's my coffee?
You okay, Mom?
Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and jelly.
Spaghetti.
You sure you're okay?
I'm fine, sweetie.
I am so late. Hey, buddy, how you doing? Hey, honey. You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Szady, my favorite. See you guys later.
Where are your shoes? Put your shoes back on, please. Go help your sister. We're going in 3 minutes. Oh my God, what am I doing? I forgot to cut off the crust. Voila. Shoes on, potty if you need it. Honey, get your sister. Okay, here. Nobody move. I'm getting a dustpan. Oh.
Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack? I'm just gonna sit down. I'm totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not gonna wait. Whoa. Okay. 9, 1, 1. Hi, sorry to bother you. I think I might be having a little heart attack. Nothing really, just some nausea, tightening of the jaw, dizziness, shortness of breath, muscle pain, achiness, this terrible pressure in my chest. Oh, really? They can be here in how long? 2 minutes. Can you make it 10? I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. that is. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org.
All right, so obviously she was busy, she's taking care of her family, right? She's not putting herself first. She's in denial. Do I look like somebody who's having a heart attack? Well, yeah, you do, right? Even your son, who's like, Mom, you're having a heart attack. When she finally does call 911, sorry to bother you. You're not bothering anybody, you're having a heart attack. That's what we're here for, is to take care of you, right? And then, of course, oh, you can be here in 2 minutes, so my house is dirty, can you make it 10, right? So, again, these are all things that, we need to think about. All right. So now we've talked a little bit about the epidemiology, some of the data. Now let's look at some of the risk factors, okay? Some of the risk factors we look at are family history of premature coronary disease. That means a first-degree male relative with heart problems or heart disease at age 50 or less, or a female under the age of 60 with heart disease. High cholesterol, right? Smoking, high blood pressure, diabetes, as Dr. Gaudiani will talk a lot more later about, as well as metabolic syndrome, obesity, unhealthy eating habits, excessive alcohol consumption, certain inflammatory and rheumatic diseases. We know that heart disease is an inflammatory process, okay? So what people don't realize, if you have an inflammatory disease such as rheumatoid arthritis or lupus, you are at an increased risk for heart disease because of that inflammation. And we'll go over that in a little bit. And also physical inactivity. So there are some risk factors unique to women, all right? Early age of your first period has been shown that each 1 year increase in the age of menarche was associated with a 3% reduction in total mortality, okay? So again, there's some of these things we can't do anything about, right? But these all add up when we're looking at our risk factors. So these are things that we need to know, all right? Early menopause. We also know that hormone replacement therapy is not protective, right? We once thought it was, okay? We know that estrogen itself is protective, but giving you estrogen supplements is not, and we've actually found it's actually harmful in some cases. We also know that having a hysterectomy, plus or minus having your ovaries removed, is not necessarily associated with an increased risk. We also know that premenstrual syndrome can be associated with an increased risk of developing hypertension. We know that polycystic ovarian syndrome can lead to increased risk for heart disease because of the metabolic derangements, that, as well as blood pressure. And certain complications during pregnancy that we really never thought about can actually increase your risk. Having hypertension during pregnancy, or we call eclampsia or preeclampsia, having high blood pressure during pregnancy, either eclampsia or preeclampsia, even if your blood pressure normalizes after delivery, you are at increased risk for developing heart disease later, okay? Same thing with diabetes. If you have gestational diabetes, even if your blood sugars normalize after pregnancy, you are still at risk for developing heart disease later in life, okay? We also know that women who've had a miscarriage in the past have a higher risk of developing heart disease, and women who've had preterm births, okay? So some of these factors we can't control, but when you see your doctor, you need to tell them, I had preeclampsia, or I had gestational diabetes, or I've had a miscarriage, or I started my period when I was 10. Those are types of things that we need to know in order to help what we call risk stratify you, to decide what your risk really is. Some of the more standard risk factors are high cholesterol. Okay, there are two types of cholesterol. There's low density lipoprotein, or LDL. That's your bad cholesterol. Okay, this is what builds up in the walls of your arteries and clogs them. If it's in the heart and it clogs it, it causes a heart attack. If it's in the brain and clogs it, it causes a stroke. Okay, high density lipoprotein, or HDL, is your good cholesterol. HDL actually picks up excess cholesterol from the blood, transports it back to the liver for breakdown. So we want a low LDL and a high HDL. Triglycerides are the most common forms of fats in the blood, And high blood glucose levels will actually lead to increases in triglycerides. So that's one of the many ways that diabetes causes heart disease. We know that being obese, physical inactivity, diets high in carbohydrates, smoking, and excess alcohol consumption can lead to elevated triglycerides. Okay? We know that high triglycerides combined with low HDL and high LDL actually speed up the development of atherosclerosis or development of plaque within the arteries of the body. Ways to lower cholesterol. Eat a diet low in saturated fats, okay? Those are animal proteins, all right, as well as trans fats. Maintaining a healthy body weight. Controlling your diabetes, all right, as I stated earlier, and we'll talk a lot more about this later. High blood sugars lead to higher LDL levels, higher triglyceride levels, and lower HDL levels. Exactly what we don't want, okay? Quitting smoking, exercising. Exercising actually raises HDL levels, okay? And we do know that the female hormone estrogen tends to raise HDL cholesterol, and as a rule, women have higher HDLs, but once we hit menopause, those HDLs do drop. And we do know that giving estrogen supplementation actually will increase the risk of cardiovascular disease in some women in some instances. So if you are going to start estrogen replacement therapy, it is very important to speak with your doctor and possibly your cardiologist before doing that. Smoking, all right. Smoking leads to damage of walls in the blood vessels, making them more prone to accumulate that LDL cholesterol, all right? It also, we know that increases the risk of heart disease and stroke by 2 to 4 times. And in women, all right, women who smoke have a 25% higher risk of developing heart disease compared with men who smoke, all right? We also know that by stopping smoking, your risk of heart disease and stroke can be cut in half just 1 year later. And as you get further out, that risk continues to decline. And as I stated earlier, the combination of birth control pills and smoking increases the risk of heart disease by 20%. Smoking also contributes to the development of other cardiovascular risk factors, including high blood pressure as well as high cholesterol. High blood pressure, we know that high blood pressure risk increases with age, okay? After the age of 65, women are more likely to develop high blood pressure than men, okay? And risk factors for developing hypertension include being overweight, physical inactivity, being an African American. We do know that African Americans tend to have higher blood pressures and be more prone to hypertension, right? Smoking, consuming too much salt, right? The American diet is full of salt, right? And it's hidden in everything, all right? So we have to be careful. Alcohol. Having more than one alcoholic beverage per day can actually affect your blood pressure in women, okay? As well as a family history and stress, which is something we all have, but learning to control your stress as best you can will also help to lower your blood pressure, all right? As well as diabetes is actually a risk factor for developing hypertension. These are our current blood pressure goals, and I'm not going to go into them too much, but according to our latest round of data from the JNC8, a normal blood pressure is 120/80 or less, okay? Between 120 and 130, you're in the elevated zone, but above 130 is where we start medications, okay? And if you're significantly elevated above 140 or higher, sometimes we have to start 2 medications at once, okay? As I stated earlier, uniquely to women, having hypertension during pregnancy, women have a almost 4-fold increase in the risk of chronic hypertension, a 4-fold increase in the risk of heart failure, an 81% increase in the risk of stroke, and double the risk of atrial arrhythmias or abnormal heart rhythms coming from the top portion of the heart. Okay, so we may have had our children years ago, all right, but those risks still carry with you the rest of your life. All right. Potential explanations of this, again, it's not completely understood, but we do know while pregnant and having the high blood pressure can lead to damage of the vasculature itself, the blood vessel walls and lining, and then other pre-existing abnormalities that have predisposed you to these episodes during pregnancy. So we need to take an OB history, even though you may have had your children 20 years ago, it still matters that you had high blood pressure during pregnancy, or you had diabetes, or other issues. The next thing, obviously we all want to have a healthy weight, but it's important for many factors, okay? Body mass index, or BMI for short, is a measure of body fat based on height and weight, okay? And this is what the medical community generally uses to determine what weight you should be, okay? So obesity is defined as a body mass index of greater than 30, and overweight is defined as a body mass index of greater than 25, okay? So we should all strive to have our body mass index less than 25 as possible, and definitely less than 30. All right, we know obesity is associated with diabetes, insulin resistance, high blood pressure, metabolic syndrome, and high cholesterol, all of which are risk factors, most of which we've already talked about. We also know that not only being overweight is a risk factor, but how you carry that weight. It's called your waist circumference, okay? And we know that a waist circumference of greater than 35 inches in women, so that's, I don't want to hit the mic again, but where the smallest part of your waist is, okay? If that's greater than 35 inches in women or greater than 40 inches in men, you're at more of an increased risk for cardiovascular disease, okay, than somebody who may carry it more so in their hips or thighs, okay? So that's another measurement that we should be taking, is looking at the distribution of our body weight. We also know that obesity is associated with inflammation. And as I said earlier, inflammation is another factor that factors into coronary disease and heart disease. So increases in inflammation lead to atherosclerosis, or depositing of that bad cholesterol in the arterial walls, okay? And inflammation can also lead to actual plaque rupture, okay? That's what happens when we have a heart attack. That plaque within the artery actually ruptures, okay? The artery is occluded by our clotting cells, and blood is cut off to the heart muscle, and you have a heart attack, okay? Obesity also increases the risk for developing sleep apnea, okay? Sleep apnea can lead to the development of hypertension, okay? And as well as diabetes and elevated triglyceride levels. And also, obesity increases the risk for developing atrial fibrillation, which is an abnormal heart rhythm that comes from the top portion of the heart, okay? And why we worry about that is that rhythm is actually associated with increased risk of stroke. I'm going to touch on diabetes for a nanosecond, because I am not the one qualified to talk about diabetes here tonight. But diabetes, we consider it a coronary artery disease risk equivalent. So what that means is if you are diabetic, we already assume you have coronary artery disease, right? We just go ahead and say you have it, because that is how much of a risk factor it is. We treat you as if you already have it, okay? Adults with diabetes are 2 to 4 times more likely to die from heart disease than adults without diabetes. And at least 68% of people aged 65 or older with diabetes die from some form of heart disease. 68%, right? 16% die of stroke. Individuals with diabetes often have other risk factors for the development of heart disease, including high blood pressure. Again, we've talked about the link between high blood pressure and diabetes, as well as elevated cholesterol levels, which we've already talked about. Again, the high triglycerides, the high LDL levels, and the low HDL levels that lead to faster development of blockages in the arteries. Metabolic syndrome is a constellation that is, I consider it almost like prediabetes, and I'll let you talk to this a little bit more, but it's a constellation of high blood pressure, low HDL levels, high triglyceride levels, high blood sugar levels, and a large waist circumference. Okay, so it's all of those kind of constellation symptoms. You haven't reached diabetes yet, but we know that these abnormal factors, you are well on your way to diabetes, and we also know that you already have significant increase for developing heart disease. So now we've talked about the risk factors, so I'm just going to spend a couple more minutes here on what we can do to prevent these things from happening, okay? The first thing is exercise, all right? Just exercising for 30 minutes a day can keep your weight under control, all right? It improves cholesterol levels. Again, it decreases LDL, the bad cholesterol. It increases HDL, the good cholesterol. It helps to manage your blood pressure. It helps to manage stress. And it reduces the risk of stroke by 20% if you are doing moderately intense activity, which we're going to get to that in a second. So these are, I always get asked, how much should I be exercising? These are the American Heart Association recommendations for exercise. We need to get at least 150 minutes a week of moderate intensity aerobic exercise, or at least 75 minutes per week of vigorous activity exercise, or a combination of both, preferably spread throughout the week, not just on a day or two. Once we achieve that, then we should add moderate to high intensity muscle strengthening activity, such as resistance bands or weights, 2 days a week. Even if you can't achieve all of this, spend less time sitting. Stand at your desk, all right? Even doing that, even light activities such as standing, can actually offset some of the risks of being sedentary. And we know that we have the more we exercise, the more benefit we get. And if we can exercise more than 300 minutes a week, we get even greater benefits. And again, we want to start out slow and do this over time, right? Not everybody's going to be able to do 300 minutes a week right off the bat, and that's okay. So what do I consider a moderate activity exercise, all right? This is what we call, quote unquote, cardio, all right? So your heart will beat faster, you're going to breathe harder than normal, but you're still able to talk, all right? Think of it as kind of like a medium amount of effort. So what I would consider moderate intensity exercise includes brisk walking of at least 2.5 miles an hour if you're on the treadmill, all right? Water aerobics, ballroom dancing, not Dancing with the Stars though, that's high intensity, for sure. Gardening, playing doubles tennis, and biking slower than 10 miles per hour. And what about vigorous intensity exercise? This is going to push you a little bit harder, you're going to get sweaty, and you're probably not going to be able to talk very much while you're doing it because you're going to be short of breath, okay? This is something like running uphill or walking with a heavy backpack, running, swimming laps, aerobic dancing, doing yard work where you're like digging a hole or hoeing the ground, something that's very intense, playing singles tennis, cycling greater than 10 miles an hour, and for those of us who still jump rope, jumping rope. So another thing we need to think about when we're exercising is, are we doing it enough or are we doing too much, okay? And what we think about how to figure that out is we look at what we call our target heart rate, okay? So your maximum heart rate is 220 minus your age, all right? So during moderate intensity activity, you want to be between 50 and 70% of your maximum heart rate. And during vigorous activity, you'll be between 70 and 85% of your maximum, okay? So overall, we want you between 50 and 85% of your maximal heart rate, okay? So if you're below that, then you need to step it up a little bit, okay? If you're over that, then you may be stressing yourself a little bit too much. We want you to cut it down a little bit, okay? So this is a table here. So say we have somebody who's 65, all right? So that 50 to 85% target zone is going to be between 78 and 132 beats per minute, okay? So that's kind of the sweet spot where we want your heart rate to be while you're exercising, okay? And almost everybody today has some form of Fitbit or watch or something that can track their heart rate, okay? So that's one thing to pay attention to while you're exercising. And finally, I'm going to end on dietary goals, all right? These are the dietary goals from the American Heart Association, okay? This is based on a 2,000 calorie a day diet is what they recommend for adults, okay? We want to have at least 4.5 cups a day of fruits and vegetables, all right? We want to have at least 2 3.5 servings a week of fish, preferably oily fish like salmon, okay? We want to have at least 3 1-ounce servings a day of fiber-rich whole grains, okay? And then looking for nuts, legumes, and seeds, about 4 servings per week, but opting for the unsalted varieties because, again, that salt will increase your blood pressure, Okay? Other dietary measures, trying to consume less than 1,500 milligrams of sodium in a day. That is extremely hard. Okay? If you actually go and look at what we buy in the grocery store and you look at the amount of salt, okay, it will shock you for sure. Sugar sweetened beverages, we want to aim to consume no more than 450 calories a week. So I think a can of soda is about 350 calories, so that's not much more than a can, okay? Processed meats, these are your sausages and cured meats and whatnot, and no more than 2 servings per week. And saturated fat should comprise no more than 7% of your total calorie intake, okay? So in summary, heart disease does remain the #1 cause of death in U.S. women. Women have unique risk factors and they have unique presentations, okay, that we need to be aware of, okay? The symptoms of a heart attack in women are often different than men, all right? Keys to reducing heart disease: controlling your blood pressure, controlling your cholesterol, controlling your diabetes, weight management, stopping smoking, regular exercise, and eating a healthy diet. Thank you.
Thank you, Anita, for setting the stage. You created such a wonderful and frightening picture of heart disease in women. I'm terrified. But this is the stuff that we need to know. Welcome to all the women who came, and special women, and welcome to the men who came, because you are the only guys in Marin who really care about your women. So welcome to the women, double kudos to the men. And I'm going to start off by saying that I sort of was listening to what Anita had to say, Dr. Szady had to say, and thinking about, well, some of this is repetitious, but you're going to kind of be looking at the car from one side and looking at the car from the other side. And then I want you to step back from the data, because this is how we get sound bits of information, but I don't always think they're useful because people don't think that way. Am I eating 3.5 portions of something? I mean, this is the way we get evidence-based medicine, and this is what we physicians have to pass on. But there's also something called physician experience and common sense. And so doctors such as Dr. Szady and I have to put this together. What the data shows, and also what we see and what we have seen in our practices, and what you, as our patients, tell us. And we have to put that all through and try to make sense of it, and so do you, as we enter into a discussion together about our health and the decisions that affect ourselves and our families. And I'm especially interested in this issue of women's health because I believe that women's health issues are central not only to the individual woman, but very much to the health of her family, as you really saw play out in that little film. So I'm going to tell you that when I first started thinking about this, and I've been thinking about it a lot because I direct the diabetes center in Marin, both outpatient and inpatient. I've been an endocrinologist for more decades than I'd like to admit to you. And I started thinking, okay, I'll just start putting in my up-to-date and my research, cardiometabolic health in women, and I'll see what the data shows. And this is what came up on up-to-date. That's what came up. Actually, if you put in cardiometabolic health, nothing comes up. And I thought that was very interesting. This word cardiometabolic is something that we've kind of just coined in terms of really the hard medical literature. Anita, tell me if I'm wrong. They don't write papers about this. So when you leave here, I want you to be the few people in Marin that leave here saying, I'm skeptical. I'm skeptical if all of this data is really true or if it's just the tip of the iceberg. And it looks bad enough, but I don't think we have a lot of data. In part because traditionally, medical research was performed in men. And I get to say this today because the topic is in women, so I can bring up the sexual differences. But traditionally, The data was accumulated for most of heart disease in studies that were performed on men only. So we have more recent data, we have more of a paucity of data, and the data we have is limited to certain groups of women, mostly Caucasian women. So as we become more diverse in our exploration, in our health recommendations, we have to think, women, it's not just all one pot. When we look at the data, in other words, be skeptical of the data, because we're looking at multiracial, and in fact, it didn't until recently look at young women. As Anita said, she brought out a really crucial factor that I'm going to talk to you about right now. If you just sort of, after looking up cardiometabolic and coming up with sort of zero about specific papers, cardiovascular disease in women, let's just sort of try to go back to what Dr. Szady was saying. Okay, there's been an overall decline in mortality in the past 40 years. I should hope so. I mean, we have statins, that was a big part of it. But interestingly and sadly, the mortality in younger women, and you need to tell me if this is wrong, but this is what I got, you're the cardiovascular specialist, it has plateaued for the past 20 years. Did we stop discovering medications? No. Have we stopped treating women for hypertension? No. What else is going on that we haven't been able to control and reduce the risk of cardiovascular disease in our daughters? I found that very, very striking. The incidence of MI, and that means myocardial infarction, which you would say a heart attack, right, dramatically increases in menopause. Is that due to age or due to other? We have all the data that came out of the Women's Health Initiative in 2003 and 4, which is what put the big brakes on hormone replacement therapy. Everybody said, oh my gosh, there's clearly an increased risk of breast cancer in some of the subgroups, at least the women treated with estrogen only. With estrogen progesterone, excuse me. And that put a major brake on that. And then there has been the last 15 years of subgroups of looking at that study. And I will just say that there's still great unknowns. There are probably out of the pie of women, and who doesn't go through menopause? Guess what? When we go through the metabolic transitions of women, you'll see, I mean, we all go through that, right? We don't get a choice. There is a tremendous variety in terms of the subgroups of women who may respond negatively, and there's clearly a group that respond very positively to estrogen. The problem is, we can't figure out ahead of time who's going to be the person who's going to be the right match for estrogen, very low risk for breast cancer, etc. It will help their hearts, and who are the people who are going to be negatively affected by estrogen. But this would certainly, again, be a huge area of future research. It's not affecting a small number of people, it's affecting every single woman. And then we have to keep remembering, again, that although we're terrified about cancer and we have every right to be watchful and worried about it and do protection, cardiovascular disease is still the leading cause of death in women. So again, I'm not going to go through this because very quickly, because this is what you just got in so much more detail from Dr. Szady, but just a few things. I was thinking again of cardiometabolic, and I started dividing it in my head. Well, what's the cardiac stuff and what's the metabolic stuff in terms of risks? And how does a seesaw go? So the cardiac risks, a risk of a prior event, age over 55, just getting older, again, who doesn't get older? That's a risk. Family history of premature cardiovascular disease as defined by my colleague. Dyslipidemia, what that means again, as Anita said, the low HDL, the high LDL. Smoking. If you didn't leave here with anything else, if you know anyone who smokes or you smoke, and you stop smoking tonight, that accounts for 50% of all the coronary events in women. Striking. On my way over here, just over by the TAM, I saw 2 young women sitting on the curb smoking. And I'm like, do I stop the car now and talk to them, or should I go back later? Hypertension, high blood pressure, cardiac risk, chronic kidney disease, and again, inflammatory and rheumatic diseases. Then I started making my list of the metabolic associations with cardiac disease. That was a big list, it turned out. 3 times as many things. Diabetes, right up there, huge. We're going to go into that in more detail, but really big. And it used to be thought of diabetes as just one of our major diseases, but actually it's affecting almost half the country. Metabolic syndrome, this is not really a disease. It is a combination of presentations in an individual, and it's kind of like playing poker. Anybody ever played 21? I'm not much of a card player, but I know that you don't want to get over 21, right? So when you put down cards of obesity, high blood pressure, glucose intolerance, doesn't have to be diabetes, high triglycerides, low cholesterol, the more of these cards you put down, the higher the risk. And it turns out that genetically, some people are predisposed to all of those. And those patients are an extraordinarily high degree of risk. It's all sounding very depressing, but half of my talk is going to actually be very encouraging. Because as opposed to a lot of the cancers where we can't see it coming, we don't know yet how to prevent many of these cancers. With heart disease, if we're smart, we can see it going. And there's a huge amount that we can do to reverse and prevent. So that's going to be the big focus of what I'm going to tell you is exciting. So again, I don't want to repeat. Pregnancy-related eclampsia, hypertension during pregnancy, gestational diabetes, very important. But again, although Anita was, oh, here, I zapped it instead of pointed it. Just remember that gestational diabetes does confer that lifelong risk of diabetes and heart disease, but you can prevent gestational diabetes. A lot of my gals who see me for a gestational pregnancy never get another gestational pregnancy, because after that pregnancy, we fix the things that caused that gestational pregnancy. And we're going to talk about that. Psychological stresses, I'm very big on the fact that we way underserve this as a risk factor. And this is, I think, the thing that I would put on the top of the list for women, actually. And that I'm not going to be able to present you a study with that. That I'm going to have to just put down my card as 35 and a half years of seeing patients and a huge women's practice. And I'm going to say it'll be sometime in the future that they'll really prove this, but little by little, there are some bits of proof. And actually, they're coming from my cardiology colleagues. They're coming from people like Dean Ornish, who had to go to great lengths, and of course most of his work actually was done, his early work in men, but who showed that with reversal of stress, with stress reduction, plaque can possibly be resolved. So we're talking about people who already have disease, who have already had events. So it stands to reason to me, if you reduce stress, you can reduce this heart disease at a much earlier stage. So psychological stresses, depression, anxiety, post-traumatic stress syndromes, very important, very much underdiagnosed, not even on the review of systems in many physical exams. If you don't ask, people will never volunteer that. They'll tell you some minor thing about they've had a cough, but if you don't ask them about stress, they won't say it, because it's hard to bring that up in a physical exam. And yet when I do, it's amazing the kinds of things I hear and how I understand how this person is progressing towards these factors, the high blood pressure, the positive heart scan, the symptoms, the diabetes, the glucose intolerance, the obesity, the cardiometabolic risk factors that I see my women patients as they sort of soldier on, being the incredible women that most of them are. Central obesity and obesity, glucose intolerance, as we said, and pre-diabetes. So again, if you lump these two together, as I'll show you in a minute, it's a pretty large number. The sedentary lifestyle we're stuck in. Again, the estrogen, progestin contraceptives in high-risk women, and we are not always sure in advance who the high-risk women are. And yet we're telling our young women, don't get pregnant until you're ready, right? So what are the choices? In the most part, they're going to be using a hormonal contraceptive of one kind or another. It's a catch-22 about being a woman, right? So could there be more research into that, and other options that they could have, and more discussion and education around that? Early menarche, that means the onset of periods, by the way, menarche. It's when the age of your first. So we are now finding that young girls are getting their periods earlier and earlier. It used to be 12 to 13. Now I think it's about 10. The average age, 10.5. So it's come way down. That means you're exposed to these hormones much earlier. And it appears to be because body weight and fat accumulation in the prepubertal body begins to trigger the hypothalamic release of hypothalamic hormones that affect the pituitary, and the pituitary in result stimulates the ovary to start ovulating. So that triggers this whole hormonal process earlier. So early menarche is associated, in fact, also with two things, as I said, weight gain, and also possibly some of the hormones that youngsters are exposed to in their foods. We know that until recently we were kind of poofing off, well, animals, whether they were fed this or whether they were fed that, but it turns out that many animals are fed certain hormones, and the ingestions of those hormones can trigger the early menarche and early menopause. Premenstrual syndrome via hypertension and stress, were touched on, but I'll get into more, and PCOS, or polycystic ovarian syndrome. So it turns out that the metabolic risks really are great, and so maybe instead of cardiometabolic, and this is kind of a joke, I said maybe we ought to be calling it metabolic cardiac or metabolo-cardio health in women. Maybe we really ought to start letting women focus on who they are, and women are constantly in hormonal transition. If you could find one difference between men and women, as an endocrinologist, it would be that men are in pretty much a steady state hormonally with their gonadotropins, with the pituitary and hypothalamic hormones that stimulate their glands, and their testosterone, their end organ hormone levels, from the time they reach puberty, biochemical puberty, not maturity, till the time of senescence. And that doesn't have anything to do with erectile dysfunction in many cases either. I'm talking about into much older ages. So women experience cyclic transitions from the time they're 10 to 12, every 30 days. Then they have pregnancy, then they have lactation, then they have perimenopause, then they have menopause. They're only 50, they ain't finished then. Then they have this long period of time when actually people used to die at that point. But no. We're living till we're 90 in a hormonal milieu that's not really completely normal. And thank you very much, we've just been told, oh, and hormones aren't good for you. Really? Maybe we're just not delivering them right. Maybe we need more research around that. So it's very, very complex. So what could we do? So again, I think we've talked about this. What does it really mean? What do the terms come from? It refers to this group of overlap of cardiovascular diseases related to, and diseases related to diabetes and obesity and all these precursor syndromes we've talked about. And together, these diseases and their complications currently account for about 50% of deaths in women. If you pile the diabetes on top of the heart disease, it's definitely over 50%, correct, Anita? This term, however, does not describe one particular disease. People don't say, oh, I have a cardiometabolic something. No. But a continuum of disease risk and disease outcomes that have enormous overlap, and good news, they have enormous potential for reversal and prevention. That's what excites me every morning. So what are some of the stats? That heart disease is the leading cause of death in women. My statistic was 1 in 3 in one and 1 in 5 in the other, as Anita said that I saw, but it's a lot in any case. Certain factors can help identify these patients. These we've talked about a lot. Under here, I put this in red. You can't see it. Let's focus on some of these more metabolic features. Again, when Dr. Szady was talking about diabetes being a primary in terms of looking at a risk factor, and she sees a diabetic, she treats that person just as a person who's already had a heart attack. Okay, now there are caveats to that for those of you with diabetes who actually are heart healthy. And I will say, I have many diabetics who I have seen at the beginning of their disease who have had perfect glycemic control, great blood pressure, amazing lifestyles, management of their lipids, and they're living very long lives, and they're going to do, I think, great. But when you look at the overall, you have to consider diabetes as equal in risk to having had a heart attack. So you have to take that person out and treat them with specially and different goals to put protection around them until you know more. So how common in this? So now we estimate that pre-diabetes and diabetes, if we lump them together, it's somewhere in the 40s to 42, 43% of the American adult population. And a really scary thing is between 20 and 24% now of children and adolescents now express chemistries that suggest either prediabetes or diabetes. So that's very different. And when you look, and these are the RISE studies, when you look at the RISE studies, which are studying diabetes in these youngsters, it's not like the diabetes that we're seeing in our 40 to 65 and 70-year-olds. It's a more virulent form of type 2 diabetes. They're more insulin resistant, and they are less amenable to treatment with oral agents and often need insulin early on. So again, another reason why we really have to look at what we're doing in the society and how we can change this. Well, what specifically about women? Women have additional specific risk factors for developing glucose intolerance at an early age. We get pregnant, and gestational diabetes is a common form, and what just drives me crazy is someone will have a gestational pregnancy and they get all this attention. As soon as they deliver the baby, it's bye-bye. Mother's stuck with all her problems. She's stuck with even more stress. Is that going to be a great time necessarily for her to lose weight? No. Are there programs for women who have had gestational diabetes to get them back where they should be before the next baby? No, there really aren't. So women have recurrent gestational pregnancies, both threatening the infant and threatening the mom. So this is something that needs a lot more attention. Polycystic ovarian syndrome is associated with insulin resistance by way of obesity. Again, last patient I saw today, 17-year-old gal. This is the kind of patient we can treat to prevent diabetes. Usually, polycystic ovarian syndrome patients come in because they're worried about the cosmetics. They have acne, they have hirsutism, they're embarrassed, they want that treatment. They're worried because they're overweight and someone tells them they're fat, and that gives them an eating disorder, and then they become bulimic. And that's another whole sort of scheme of stress and problems. And so instead, the conversation has to be very different. It has to be talking to them about prevention. It has to be talking to them about getting comfortable with the bodies they now have and appreciating those bodies, and learning the lifestyles that can help them prevent heart disease and diabetes with no guilt trip, with no reference to beauty points, which add to the early development of body dysmorphism that women have. Dysmorphism, does that make any sense to you guys? Dys meaning off or not right. Morphism, the body. I think that it's the rare woman in our culture who doesn't have some degree of body dysmorphism. Women look in the mirror and all they can see is that one part of them that they don't like, right? They hardly ever come in and say, yeah, I'm great, I'm beautiful, I love the way I look. No. Never happens. You can have the most gorgeous person in the world come into your office who's just basically practically perfect, and she's like, oh God, I just hate this about myself. Something in the culture does that. It's a little different with men. Men are not that hard on themselves. So this is a place where polycystic ovarian syndrome and all these prediabetes and diabetes and gestational diabetes, what gets heaped on those women is often a lot of guilt and body dysmorphism that leads to eating disorders. Another whole issue that causes problems. Obesity and preeclampsia, again, these additional risk factors. Gestational diabetes increases the lifetime risk of developing diabetes by at least 2, if not 4, and it can be prevented. I think we said that. Polycystic ovarian, I'm going to skip over this. Premenstrual syndrome, I'm so glad that you mentioned that because I think that's very little appreciated. Do you guys all know what premenstrual syndrome is? The guys don't, the girls do maybe. Okay, so we define that as sort of a group of constitutional symptoms that are associated with the days before the onset of menses, usually with some physical and emotional stresses, and they're usually kind of particular to a person. They know when they're getting their period. Everybody has a few symptoms, but for some people it's really quite marked and can cause a lot of stress that is associated with the development of hypertension later on. So there may be an abnormality or a difference in their hormonal milieu during those weeks. When you think about it, the premenstrual week is 25% of the month. And that means 25% of your menstruating life of age, 13 to 53. So that's a lot of your life if you really have bad PMS. And again, it kind of gets written off in most cases as women are neurotic, like many of the things that we complain about. That's what women have been told in the past, and my experience taking a lot of histories. So how else might women be exposed to additional cardiometabolic risks other than those diseases? Well, we have to take contraceptives, but now what about all these hormonal manipulations to become pregnant? When a woman wishes to become pregnant these days and the infertility is occurring at a rate of over 10% of all couples have some degree of infertility that they seek evaluation for, many of those women end up with hormonal interventions. And those hormonal interventions are often extreme, and they can potentially expose patients to additional fluctuations in their weight and possibly due to other risks. We don't have the data. I haven't seen data that says in women who have undergone repeated IVF, do they have an increased risk of cardiovascular disease after? Have you seen that? Haven't seen it, but it would be nice to collect that data, to look at that data. Pregnancy is associated for most women with weight gain. And again, although we do a lot of preparing for the baby and take care of the baby and the pregnancy, as soon as the woman has the baby, she's zeroed out. I think there needs to be as much nutritional attention postpartum as prepartum, and also to get the patient ready for her next Olympic event, for the next baby. And that rarely happens. Instead, when I see a 45-year-old woman who's coming to me because she hates her body, which is at least a significant part of my practice, for one reason or another, she says, yeah, I'm 35 pounds overweight now that I'm 50 and I'm going through menopause and I'm terrified. But it didn't all happen at once. I gained 10 pounds with George and 10 pounds with Mary, and she had 3 pregnancies, and she never lost in between those pregnancies and got back to her usual pre-pregnancy weight. And so it just accumulated over her reproductive years, and then she was stuck with it when she went through menopause. There are some additional cardiometabolic risks associated with clotting risks associated in pregnancies with preeclampsia again. And going on to this peri and postmenopausal hormonal replacement therapy, I just don't think we've seen the end of that, but it's going to be really hard to study, because once we have this huge study, it was done in over 200,000 women, that WHI study that showed the breast cancer increase, they're not going to do another WHI study. And yet it could be that there is a place for some kinds of hormones which could be developed in research that would be helpful in some women who are living, again, long lives. And because there is that data in the Framingham Women's Study, certain heart-healthy women who were treated from the time of menopause, not in their started in their 60s, but from the time of menopause going forward, seem to have a reduced risk of cardiovascular disease. And we know there have been numbers of studies like that in subgroups, and we just had to kind of sweep those to the side because it wasn't as pressing as reducing the risk of breast cancer.
There's also the risk of stroke as well. So that's another thing in certain populations,
exactly.
Certain length of time.
Estrogen sort of doubles the clotting risk. But if your clotting risk is low, 2 times a small number is a small number. But if your clotting risk is high, which again, right now, this is something someday we may be able to go in and say, test my clotting factors, test this, test that, and then we may be able to sort of profile a woman as to what will be her healthy postmenopausal care. And I think that will come. I'm sure that we will tailor-make our postmenopausal therapies in the future. We're just not there yet. So I said that right here. The hormone replacement therapy is known to increase the risk of breast cancer, but also it doubles the risk of clotting disorders, doubles the risk of thrombophlebitis, increases the risk of strokes, insusceptibles, might increase certain lipids such as triglycerides. Certainly in the diabetic population, estrogen increases triglycerides, so we have to be very careful and monitor those patients. Might predispose them to atherogenesis and might affect blood pressure and in some cases elevate the weight. Yet, every woman has to deal with these hormonal transitions, as we discussed, and I think you can see these here. And we haven't talked to this yet, but on the other end of perimenopause and menopause are in our older women, and we now have many women living into their 80s and 90s, full, rich lives. These patients also are facing hormonal changes, age-related frailty changes, loss of muscle mass. Is there any relation between that and cardiovascular disease? That's pretty much unknown. Obesity, women experience a myriad of hormonal fluctuations that trigger these physiologic weight gains and accumulations. Puberty, menarche, pregnancy, lactation, all of these also cause stress. Obesity, the obese cell can be thought of a stretched cell in which the receptor for insulin is not normal anymore. So insulin doesn't work as well. So the more fat cells you have, the more insulin you need. If you have an inability to make lots of insulin, like the gene for diabetes, this is what increases the risk of diabetes and glucose intolerance in the patient who simply has too many fat cells. So when we try to treat to prevent diabetes, we're trying to reduce the amount of fat cells, the amount of fat organ present to reduce insulin resistance so that the amount of insulin the patient has might be enough. Diabetes affects both large and small vessels, resulting in vascular disease, resulting in thickening of the vascular vessels, the walls, results in leakage of small proteins into the kidneys, abnormalities in the liver, with fatty accumulation in the liver, and also abnormalities of the kidneys and nerves that are caused by the abnormal glucose levels. And lastly, fat cells can elaborate inflammatory agents, as Dr. Szady mentioned as well. What about stress? Again, mounting evidence that these stresses cause glucose intolerance, worsen diabetes, increase cardiovascular risk. Also evidence that stress reduction can assist cardiovascular disease in remission, improve blood pressure, it improves and lowers glucose intolerance, it reduces the risk of cardiovascular disease recurrence. But women face mounting stressors and receive inadequate support for stress reduction. You're not going to find a paper about this. That's just me. Hormonal management house rules. What could we do about this? Well, I believe that these hormonal transitions that all women face need to be discussed with women in advance. Women need to be prepared for them in advance so that they can be prepared to meet them optimally. These choices that women are making about their contraception, about their timing of family, about their careers, they need to be highly individualized and include their physicians, which often they do not. The risks and benefits of different approaches should be explained on the basis of medical evidence and physician experience, and hormonal support really can be individualized and risks can be minimized, but never eliminated. Monitoring regularly and keeping a dialogue going back and forth between the patient and the doctor is really important. I think this is changing as we have more women physicians and more men physicians who are really very much more attuned to their women patients' needs and do enter into these kinds of dialogues, but it's still far from perfect. What are these new stresses in women? You really saw it perfectly in your little skit. Maybe that seemed silly, but on a more serious level, women today are managing education, their educational needs, along with their careers and their traditional family and home rules. Most women report that they don't have time to exercise regularly. They certainly don't have time to meditate or to recreate. And there are more single parenting being done by young women than by men, resulting in work plus single parent demands. There are more women, single women, taking care of families than single men. This doubles their stress. They're under economic stress, they're under work stress, they're under family and personal stress. Does it end when their kids go off to college? Not really. I look at my women in their 50s and 60s and 70s where women used to be able to kick back. No. The women in the middle years, they're assisting their children. Their children are moving back home with them. They've got grandchildren who sometimes they become the nannies for. Oh yeah, you're nodding your heads, right? As well as taking care of their parents, who are now used to die in their 70s, but hey, my mom's turning 97 next week. So thank the Lord we have these people living into their old age, but for that sandwich generation of women who have children and grandchildren and their parents, they're not sitting back in their 60s and 70s and having an easy ride. Some of them are really working as hard as they ever did and getting very little support. I'm glad that they're doing it all. I'm just saying I find a paucity of support and mental health awareness. Many women certainly don't have time or resources for optimal nutritional meals, so although you put all those meals out perfectly, and you're absolutely right, I wouldn't argue with a single one of them, I think most women would laugh at it and just say, I don't have time, right? And we haven't taught them how important it is. Unfortunately, on the other end of the spectrum, what women don't realize is if they don't exercise, not only do they get fatter, but they lose their lean body mass. You have a progressive, after age 70, you have sort of a progressive loss of bone and muscle, leads to osteoporosis, but it also means that you have a greater proportion of your body that's fat, even if you're staying the same total body weight, which is why that recommendation about not only aerobic exercise, but some sort of lifting exercise, although that has to be done in caution, because now you're talking about more elderly, frail people who may have osteopenia or osteoporosis. They can't just be told, go to your gym and start lifting weights, because that's the recipe for a fracture. And then what I see, unfortunately, is that I see alcohol intake, being used for stress reduction very regularly. It's very accepted, especially here in Marin. I commonly, will take an alcohol history and it'll be like, I have a glass or two of wine every night. I'm like, really? Yep. Why? It relaxes me. It relaxes me. Sedatives relax you, Are we so uptight that we have to come home and have a glass of wine? That's different from people who, mama who had a little sip of wine with her dinner at night. This is like, I have to go home and have that glass of wine to reduce my stress. So what that says to me is people are kind of self-medicating, and I think that worsens weight gain, it worsens mood disorder. Nobody who's had 2 glasses of wine at dinner wants to pop up in the morning and go to the gym. Let's be honest, right? And then women will come to me and say, I can't figure out why I have this weight on. I don't eat much. And if you just look at what they eat, they're right. They don't eat much. But if you do the calculations on 2 glasses of wine every night, it's a lot of calories. And so what's going to happen to that? That can easily be 10 or 15 pounds that maybe they don't need, plus it's keeping them from the gym. But again, it's a simple little thing that a lot of people aren't paying attention to. So I think the primary prevention of cardiovascular disease in our women is really poor. I think that having people like Anita come out and show you what she did is just so crucial, because women are not taught the signs and symptoms of heart disease. The signs and symptoms of heart disease that are out there in general are those for men, which are not typical for women. And there's just so much less data, fewer studies, less research in women's cardiometabolic health. They receive less screening and treatment because their risk was traditionally thought to be less than men's. Wrong. So what could help? We said education. We've got that. But that education has to start really young, because now we're talking about that spectrum from young girls all the way up to older ladies. Rigorous screening and monitoring, physical and psychological, evidence-based lifestyles of regular exercise, healthy diets that promote normal body weights, avoidance of excessive alcohol, pain meds, sedatives. Oh my gosh, would you please know insomnia is not a disease, yet most doctors will be glad to give you a pill for it, first thing off. I can't sleep, okay, write your prescription. No. Increased access to mental health services, that's another thing that we really need across the board, but especially I think for our women patients. Changes in the workplace and health incentives so that women and men can work together on this. It does take a village. It takes cultural and ethnic sensitivity. The recipe for one woman is not the recipe for the next. We doctors have to be better about listening to what is going to work and tailoring it to our patients. This is a multidisciplinary field. It has to have our doctors, it has to have our nutritionists, our healthcare workers. Exercise folks ought to be part of regular medicine as far as I'm concerned. Financial security is a big piece. When people are financially insecure, they can't get any of this help. Legal support when needed can be crucial. I cannot tell you how many young women, mostly, occasionally a man, comes in complete crisis over a financial situation that may stem from, let's say, my husband left, I've got 2 children, I don't have a job, I wasn't trained to do anything. Right now, we don't even know where he is. How am I going to pay the bills? What about my kids? What do I do? That causes hypertension, and in my book, I think that's a recipe for a heart attack. Awareness of abuse and neglect of women of all ages. Another thing, if we don't ask about it, we won't find out about it. And it's very moving. It's very difficult for patients to admit this. They never want to tell on their relatives. They never want to admit that it's happening. But if we doctors don't spend time on that, again, under that big thing of stress that I think women carry around, this is a big one to at least ask about. Most of my patients who don't have it always say, it's nice to be asked, thank you. I feel like you care that I'm safe. That's the kind of bottom message. Awareness of addiction risks and eating disorders and body dysmorphism that causes negative and self-abusive behaviors. Because a lot of these things we're asking people to do are really not that hard. If they had cancer, they'd go get some chemotherapy where their hair is going to fall out and they won't be able to eat for months to save their lives. But if you tell them to change their diet and exercises, they don't. And it's because they're not buying into their wellness yet. They don't see the risk for what it is, and they don't sort of generate enough positive feelings about themselves. I think that's a little more typical for women than men, but I think it exists for both. And what about sex? Sex, sex, sex? Whoever asks about that? We talk about stress. We don't talk about sex with women enough. But you turn on the next baseball game, and I guarantee if you look in the stands, you're going to see Viagra, these huge signs, you know, right up along the fence. If somebody gets a home run, it's right over Cialis, you know. Oh, man, wow, what is that saying? I got it. You know, those guys are not dumb who did that advertising, all right? What about women? Are there 3 drugs that give us better orgasms? Anybody know them? If so, please tell me. Okay. All right, girls, you're blushing. But when was the last time your doctor asked you how good your orgasms are? Or if you even have them, or if you talk about it with your husband. But you know what? Sex is a great stress reducer. And losing our sexuality can be a choice. It can be something that we come to together in a relationship or at a place in our life. I'm not saying it always has to be there. But I'm saying it can be inquired about as something valuable to a woman and should be. And I will tell you that compared to the number of drugs and medications that have been researched and that are available for men, there is almost nothing on the market for women. And remember, we were told that estrogen, we can't take estrogen either. So yeah, you can be 53 and have a dry vagina for the rest of your life and have trouble with, you know, arousal disorders. And is anyone going to do anything about it? Well, look under the table. I don't see much coming. And I'm a researcher, so we regularly, you know, my partners and I have been getting my younger partners interested in this. We're looking online for these new drugs coming down the line. Very little coming. I think that this is something where we need more attention. We need to at least use what we have, because we're in this whirlwind of stuff from Viagra. Plus, if you turn on the radio in the morning, you'll hear that one ad that for $99, guys can get an ultrasound. They're talking about prostate. And plus, they can get packets of Viagra and testosterone in the mail. You know, I mean, you don't even need a regular doctor to prescribe it, right? I'm not saying there's anything wrong with that or that I'm unhappy that men aren't getting attention. I just think that there's a disparity. And I also think when you really look at it in a very mature way, think about how disruptive that is to a relationship. Men are getting Viagra, they're getting fixed, they feel better, and their counterparts are kind of nowhere in the relationship, and they may be having real problems, and that can threaten and disrupt potentially a relationship. And what you really want to do is do everything you can to foster the relationship. So we need a lot of work with that. We are looking for therapies for this because the drugs are difficult, but I will say there are creative ways to discuss this and work on this that I work on with my women patients. And I do think that bioidentical hormones locally applied are very safe and are not widely used in our older patients. And by older, I mean even just over 45 when patients are beginning to get these problems. And that could be a big stress reducer. And again, does this come back to cardiometabolic health? I think kind of it does. So that's about prevention. Obesity prevention, I think, is the single most critical metabolic goal to prevent cardiometabolic disease. And I think we have to do it in an environment that encourages diverse body types and images. So while we want to achieve weight loss, we have to be very careful that it doesn't boomerang. I think that women's cardiometabolic health will not improve in a setting of psychosocial stress, inadequate replenishment resources, and self or external criticism. If you want to know more about that, I'll talk to you about it after. What might a community do to improve women's cardiometabolic health? Lou, this is the take home for the foundation to me. I think we need to create a multidisciplinary comprehensive women's health and resource center dedicated to education, dedicated to implementation of evidence and experience-based medical, mental health, lifestyle, and social support to women of all ages. I don't think that every community can afford to do that. I think that our community can, and we should, and we will.